Well, good morning, everyone. It's another bright, cloudy day in Madison. I think it's been cloudy for over 14 days in a row, and we've added 9 minutes of light since last week. So once again, we're kind of getting into spring is coming. So welcome everyone to Grand Rounds this morning. Again, thank you for spending an hour with us, increasing your medical knowledge. And today we have Dr. Jennifer Poehls, who's going to be giving Grand Rounds to us, and the title of her talk is Making Sense of Glucose Sensors, a Guide to Continuous Glucose Monitoring for the Internist. Clearly something I'm looking forward to hearing from. Dr. Poehls is an clinical associate professor in the Division of Endocrine, Diabetes, and Metabolism here at University of Wisconsin. So all the endocrinologists who are in the audience, I remember, like, if your PEEP is up here, I'd like you to kind of move to the front, so think about doing that. So just a little bit about Dr. Poehls. She did her medical school here at University of Wisconsin School of Medicine and Public Health, where she was AOA. She did her internship at the University of California in San Francisco, where she also did her residency. And then we were lucky enough to have her come back and do her fellowship here in endocrine, diabetes, and metabolism. She joined us on faculty in 2010 and was promoted to associate professor in 2017. And one of the things I really noticed in looking over her CV is she is a true clinician educator. She has a significant part of her life that works with education and learning. And so I just want to go over a few of those things for you because they're very impressive. She is the Endocrine Fellowship Program Director. She is a longitudinal teacher coach here for our medical students. She also does significant other medical student work. She's involved as a group leader for the Food, Fasting, and Fitness course, and she also is involved with the medicine residency internship lecture series. A couple honor things that I noticed when I was going through her CV. I always like to talk about some interesting things about people. She received the Excellence in Endocrine Teaching Award that was awarded by the Endocrine Fellows. I think it's always fantastic to be nominated by learners. And when I was looking through her CV, I also noticed that she, in her undergraduate time, got a certificate in women's studies, which I thought was fantastic as well. So with that, Dr. Poehls, welcome.
Thank you. Good morning. Thank you for that introduction, and thank you for the opportunity today to talk to you about continuous glucose monitoring. Perhaps for some of you it's new or your very recent development in your practices, and I hope that by the end of the talk today that you're able to make a little more sense of this rapidly advancing technology. I have no disclosures today. How many of you in the audience recognize what this apparatus is? Anything? I see a few hands. Well, monitoring glucose has always been a part of an insulin user's life, part of their daily routine. And what this picture here represents is one of the first home monitoring glucose devices available first in the 1940s. And what it involved was collecting urine, boiling it over an alcohol burner, and then observing the color change after adding a chemical reagent. So things have changed quite a bit since then. And the next question I will pose to the audience is, how many of you are familiar with these devices here on the screen? A few more hands are going up, which is good, and I hope by the end of the talk today that you're even more familiar with the new devices that have really revolutionized how we manage our diabetics, particularly diabetics using insulin. My learning objectives today are to outline the available evidence that has been published supporting the use of CGM. I hope to review various types of CGM so that you're able to recognize them in practice and perhaps remember a few specific features each entails. One of the key parts of this lecture today for this audience is to help you to identify which patients will be appropriate candidates for CGM. It's not a one-size-fits-all, and really the key to success with continuous glucose monitoring is patient selection and ongoing education. We'll talk briefly about how CGM can be used as an adjunct to the good old A1C that we're used to using to assess glycemic control. And then we'll spend a few moments interpreting a few components of the standard report that is provided from CGM downloads. So what is CGM? We're all familiar with glucometers, and the important thing to note is glucometers require a Lancet device to stimulate bleeding, either in the hand or in the forearm, and the serum glucose that's being measured is from capillary blood, down here. With a CGM device, these are typically small, flat devices that are packaged in like a Lancet device that inserts with a needle a small filament that goes just under the surface of the skin. This sensor here is only about 4 millimeters thick. And CGMs are monitoring the interstitial fluid. So they're not exactly measuring the same thing as a glucometer. And it's important to remember that because sometimes the CGM data or patients will comment that their glucometer and their CGM are varying, and that's because there can be a 10 to 15 minute lag in the interstitial blood glucose as opposed to the capillary blood glucose. But these devices have really exploded. The use of these devices has exploded over the past few years, and I would say approximately maybe 20 to 30, maybe up to 40% of some patient populations of type 1 diabetics are using some form of diabetes technology. There are, of course, also insulin pumps, but that's a whole nother lecture. Today we'll be focusing on the continuous glucose monitor. Next, we'll go through the evidence supporting the use for continuous glucose monitoring, or CGM, as I'll refer to it for the rest of the talk. Over the past decade or so, there's been greater than 25 published randomized control trials assessing the outcome of CGM use. Each individual trial has a relatively few number of patients as opposed to some of other randomized clinical trials that you're used to seeing. But in mass, it involves nearly 4,000 patients. And that cumulative evidence has indicated CGM benefits patients with both type 1 and type 2 diabetics using multiple daily injections, MDI, or continuous subcutaneous insulin infusion. You'll see it referred in my slides to CSII, and that refers to insulin pumps. So next I'll talk about the different groups of randomized controlled trials. No need to pay attention to all the fine details. These first two groups of studies are focusing on adults with type 1 diabetes. I'll just draw your attention to the number of patients in these trials. Again, they're small. But the take-home points from these studies are that there was demonstrated reduction in A1C of about 0.5% when patients switched to using CGM, particularly in the larger studies. And A1C reduction was greatest in studies where the baseline A1C was higher to begin with. So patients who weren't as well controlled benefited the most from adding CGM to their therapy. But one of the most important themes from all of these studies, not only those looking at A1C as an outcome, but also hypoglycemia, is that consistent CGM use is what resulted in the greater likelihood of improved glycemic control. And you'll hear me talk on that point throughout the rest of the morning. This is a group of studies that looked at adults with type 1 diabetes, and hypoglycemia was the primary outcome. They weren't powered to assess A1C outcomes. Patients in these studies were selected if they had a high risk for hypoglycemia. And so a lot of them, if you have frequent hypoglycemia, already have a lower A1C, and you may not see a big change in A1C when you're evaluating them. However, what they did see was that there were significant reductions in the patients using both multiple daily injections and insulin pump therapy. And the hypoglycemia reduction was greatest for those at highest risk for hypoglycemia, particularly those patients who develop hypoglycemia unawareness. The next groups of studies combined adults and children with type 1 diabetes. And these also confirmed a reduction in A1C, particularly in the patients over the age of 25. And that's why CGM use is approved for children over the age of 2, but the benefits in the trials were greatest in the adults. And again, in these studies of adults and children, A1C response correlated to the amount of time the patient used the CGM. More consistent CGM use led to greater A1C reduction. In terms of hypoglycemia as the primary outcome in studies looking at both adults and children, there was no significant change in A1C again, but as similar to the studies looking at just adults, there was a significant reduction in hypoglycemia, both severe and particularly for those patients at high risk for hypoglycemia. What about type 2 diabetics? There have been multiple trials over the past decade that have been published looking at the effect of CGM in type 2 diabetics, and a lot of these studies are pretty heterogeneous. Some have patients who are only on multiple daily injections, some have patients who are on orals compared to type 2 diabetics who are just on basal insulin, some compare multiple daily injections to insulin pump. But the majority of these studies, regardless of what the patients were using to control their diabetes, did show a reduction in A1C. Again, it was modest, anywhere from 0.5 to 0.8%, but consistent use again was associated with A1C improvement. There was not a significant reduction in hypoglycemia like that was observed in type 1 diabetics, except in the REPLACE trial, which was published in 2017 by Hack and colleagues. This was one of the larger trials, and it showed that the time less than 70 milligrams per deciliter was reduced by 43%. This is one of the newer trials with one of the newer sensors. And when we talk a little bit about sensor accuracy, that might play a part into the variability of the study results. There was a significant reduction, particularly for patients less than 65 in A1C. Sorry about that. Last month, as I was preparing for this talk, it seems like every journal I got, there was a new study showing the benefits of CGM compared to other ways to monitor glucose. And this study, published in Diabetes Care last month, was a long-term follow-up of the Commissaire study. So in the Commissaire study, they compared patients who were randomized to a real-time continuous glucose monitor and either were on multiple daily injections or sensor augmented therapy. The real-time real-time continuous glucose monitoring data is in the blue, and it compared type 1 diabetics. that were using glucometers and either multiple daily injections or continuous monitoring. And you can see the addition of continuous monitoring alone had the greatest effect on improving A1C. So whether you were on multiple daily injections or an insulin pump, the improvement in A1C was significant compared to those using a glucometer and multiple daily injections or a pump. And that persisted for the length of the study. Next, we'll focus on reviewing the different types of continuous glucose monitors available and their specific features. Continuous glucose monitors can be classified in several different ways. There are professional or blinded CGMs that providers can offer in their clinic as a service to their patients. We offer those in our diabetes clinic. And professional CGM is typically blinded to the patient, but it allows the patient to wear a device to potentially see if it's something that they would be able to tolerate. And the provider, or after the patient has worn the device for a week, we typically ask them to record their diet, their activity, their insulin dosing. They send that log and the sensor in, and the provider downloads the information and reviews it with the patient. So it can provide a lot of insight into an individual's glycemic control. Then, of course, there's personal CGM, or unblinded, and there's a variety of different types of personal CGM devices, which we'll review. They fall into two main categories. There's the Flash CGM, and there's Real-Time CGM. And we'll talk a little bit about those in the different types. And we'll talk briefly also about the brand new implantable continuous glucose monitor, not currently available at UW, but hopefully in the future it'll be another device we'll be able to offer our patients. So the types of professional CGM available are the Freestyle Libre Pro. This is blinded to the patient. The patient arrives to clinic, the educator places it in their arm, and it takes about an hour for it to become activated. And the patient can wear it up to 14 days, but in the clinical setting, we ask them to wear it about a week, record their diet, activity, insulin dosing in a log, and then submit that for review. Some benefits of this system is that it does not require any calibration. It's easily downloaded in clinic to compatible Freestyle Libre Pro software, and it has a pretty good accuracy. The calculated MARD is 12.3% for this device. You may be wondering, well, what is that MARD? I did when I was preparing for this talk, and it's a measure of CGM accuracy. And what's happening, and you can consider MARD as the key to assessing how accurate a device is. And what the MARD is measuring is that it's comparing a CGM reading to a gold standard blood glucose reading. And in the literature, that gold standard tool for analyzing serum blood glucose is the Yellow Springs instrument. And if you subtract the YSI, or if you subtract the CGM reading from the YSI and divide by the YSI, you get the MARD. And the lower the MARD is, the greater the device accuracy. And I think it's really important to point out that the accuracy of CGM has really dramatically changed over the past 10 years. Just 10 years ago, the average MARD was well over 20%. And when I first started practice, it wasn't uncommon for patients to come into my clinic and say, I just can't stand this sensor. It's always off. It's always beeping. It's never right. And then they stop using it. With the advances in technology over the past recent years and the improvement in the MARD, it's much less frequent to hear my patients say that about their sensors, and so it's made me really excited about their potential. But I want you to consider this fact that the accuracy of the sensors probably used in some of the initial trials wasn't the greatest, and that probably impacted the magnitude of those results. So just pay attention to the MARD as we're going through. The other type of professional CGM is the Medtronic iPro Enlight sensor. This again is placed in clinic by one of your nurses. It has about another hour, or it also takes an hour to warm up, and it's worn only about 5 to 6 days. It doesn't require calibrations, but it works better if the patients are calibrating at least every 12 hours. The difference between the Medtronic and the Freestyle Libre is that the Medtronic is a continuous CGM, and so it's continually collecting data, and if there was a reader available, the patient would be able to monitor that, as opposed to a Flash CGM, which is the Freestyle Libre. It requires the patient to scan the device in order to see what the glucose reading is. The MARD for the Medtronic iPro 2 is 13.6%. I got ahead of myself here. So the difference, again, between the intermittently scanned or Flash CGM, the big difference between the two is that the currently available Flash CGM does not have any alarms. In order for the patient to get any benefit out of the intermittently scanned CGM, they have to physically scan with their reader or a smartphone with an app downloaded, and use the data that is transmitted that way. Real-time CGMs are continuously monitoring the sugars and alerting the patient as to whether they're going low or perhaps going high, depending on their alarm settings. And it's only the real-time CGMs currently that are available for use in conjunction with insulin pumps. One other aspect of personal CGM devices is whether they're adjunctive or non-adjunctive. Adjunctive means that the device requires the patient to check and confirm with a glucometer reading the result on the CGM before making any treatment decisions. And that was the standard up until very recently. I think 2018 was when the Dexcom G6 came out, and when the Freestyle Libre came out. And when these devices came out, it was because of the Aleppo Replace blood glucose trial. They compared well-controlled type 1 diabetics and randomized a small group to either CGM or CGM plus blood glucose. And the primary outcome of this study was whether there was a difference in time and range. And what they found was no difference. And so based on this study, they were able to conclude with certain devices that you did not need to confirm your CGM data with a blood glucose check. And then that allowed for approval of the newer devices that do not require an adjunctive blood glucose. So now getting into the personal types of sensors, the Abbott Freestyle Libre, very similar to the professional CGM. This one actually came out in 2017. Patients can wear this one for 14 days. It can only be worn on the back of the arm. The nice thing about this device is that it doesn't require any calibrations. And the personal device has a slightly improved accuracy of 9.7%. But again, this device does not alarm a patient if they're going high or low. It physically requires the patient to wave their reader or phone over the sensor in the arm to get the readings. Next, we'll talk about the various real-time CGMs. There's two main manufacturers. The first we'll discuss are Dexcom. Dexcom has been around for a while and has had various versions of devices released. One of the earlier advances with the G4 therapy or the G4 device was that it had radio waves that connecting it to the transmitter and the pump. The G5 device advanced to Bluetooth technology. And now the G6 device, approved in 2018, can be worn up to 10 days, does not require any calibrations. It's compatible with the Tandem insulin pump products. And with the new software and improvements in algorithms, the MARD for Dexcom G6 is 9%, and one of the advantages is you can download the G6 technology if you have an older pump to gain the same sort of accuracy. The other company producing real-time CGMs are Medtronic. These were the first to be incorporated with an insulin pump. The two available currently are the Medtronic Enlite, a sensor with mini-link Guardian that can be used with the Medtronic 530 and 630 insulin pumps. These sensors can be worn up to 6 days, and they do require calibration, unlike the other devices. But one advantage of this system is that because it communicates with the insulin pump, it has something called SmartGuard. And so what happens is if the sensor is reading or registering that the blood sugars are going low, and if the patient isn't responding to the alarms, it will turn off the basal rates in order to help protect the patient from a severe low. So kind of the first step in artificial pancreas. This paved the way for Medtronic Guardian Sensor 3 and the Medtronic 670 closed loop system. The difference with this device is that if it is turned on in the auto mode, the sensor data will, as opposed to only turning off basal rates when a patient is low, like with the Enlite sensor, with the Medtronic 670G and the Guardian, the sensor will adjust basal rates according to what the blood sugar trends are to help keep the patient in range. Now, the MARDs for these devices vary depending on how often you're calibrating, particularly for the Guardian and 670G. The accuracy of this device improves if you're calibrating with a glucometer more frequently and if you're wearing it in your arm as opposed to the abdomen. So there's a little more variability in response to this device, and it's not for every patient. Just a brief word about Eversense CGM. Just a disclaimer, I don't have any patients using this technology yet. It was just approved in June. It's an implanted sensor that requires a small office procedure. It can be worn for 90 days. It does take a while to set up. It's not, it requires several calibrations the first few days that it's on. But once it's up and running, it communicates with an app on your smartphone through Bluetooth, and it has published pretty good accuracy. I hope that we're able to offer this to our patients in the future, so stay tuned. So you might be wondering, is there a benefit in terms of glycemic control as opposed if a patient is using a flash sensor or intermittent scanning sensor or a real-time? And Reddy et al. Published in 2018 a randomized control pilot study of CGM and flash glucose monitoring in type 1 diabetics with impaired awareness of hypoglycemia. It was a small study. Only 20 patients randomized to the real-time sensor and 20 to the flash sensor. sensor. But these were patients who were at very high risk of hypoglycemia, patients who've had a severe event in the past 3 months or have developed hypoglycemia unawareness. And when they assessed the primary outcome of time spent in hypoglycemia, those using the continuous real-time sensor had less time in the hypoglycemic range than those using Flash. 2.4% versus 6.8% respectively. And so something to consider when you're discussing the option of sensors for a patient. If you have a patient that is having a lot of issues with lows, the continuous sensor may be a better option. A little more about what to consider when you're selecting a patient for use of CGM. This is really critical because selecting the patient patient selection is key to CGM success. Patients that you would want to consider continuous glucose monitor are any type 1 diabetic over the age of 2. But particularly those who are going to adhere to it the most. If the patient invests in a sensor but doesn't wear it because of skin irritation or issues with placement or what have you, there's not going to be a benefit. Type 2 diabetics should be considered for CGM therapy, particularly if they're on insulin. And in 2017, Medicare and Medicaid began covering Dexcom and Freestyle Libre for both type 1 and type 2 diabetics who on insulin pump therapy, or those type 2 diabetics who are using greater than or equal to 3 injections of insulin a day. Pregnant women or women planning to get pregnant who have diabetes would be an excellent candidate for sensor use. It would be a great tool to help them optimize their therapy before conception and then during pregnancy. And then, of course, patients with hypoglycemia unawareness, but also consider those patients who have such a significant fear of hypoglycemia that it has really limited your ability to titrate their doses to improve their control. Besides patient selection and consistent wear, other keys to patient success are how often the patient is actually looking at the data and using that data to make changements in their lifestyle, whether that is diet choices or exercise. And another key to success is getting the patient involved in the data analysis. So if a patient is counseled to look at the device and see how quickly their blood sugar is rising after a certain meal, they may recognize that they need to be bolusing sooner or that maybe their carb ratio is inadequate. And so really involving the patient in the interpretation improves their success. And I can't stress enough the importance of initial and ongoing education, not only for the patient, but for the provider and the staff in your clinic. Even though we are a diabetes clinic, it's the technology is changing so rapidly that it can sometimes be very overwhelming to stay on top of it. And I will provide some online resources at the end that you could use with your patients to help navigate the expanding field. One thing as a primary care provider that would be really useful is really setting realistic expectations for CGM with your patients. There are a lot of misconceptions about what CGM is capable of. Some patients feel that if I get a sensor, I won't ever have to check my blood sugar again. That's not really the case, even with the devices that don't require calibration. It's always important that no matter what your sensor is reading, if you're not feeling well, if you're having hypoglycemic symptoms, it's always a good idea to confirm what you're seeing on the sensor with a glucometer check. Another common misconception is that CGM will automatically adjust all aspects of the insulin pump. And I hope I demonstrated that we're really not there yet. That's the goal in the future. But the CGM is just a way to augment sensor therapy, but patients still need to count their carbohydrates. They still need to enter those into the pump and bolus for their meals. So CGM is not going to take away the work of diabetes. Really, there's nothing available yet that's going to allow the patients to have a completely hands-off approach to managing their diabetes. Another common misconception, not only for the patient but for the provider, is that all of that information is going to be welcome. There definitely are cases of information overload on the patient part and alarm fatigue that leads to device abandonment. And so counseling patients on how to set the alarms so that they aren't constantly being awoken in the middle of the night, and giving patients a permission to take a break from their sensor, because having that constant data all of the time can be overwhelming and distracting. What is true, though, is CGM use is growing rapidly due to the improvements in accuracy, the greater convenience of use, and the expanding reimbursement. But successful utilization in clinic remains low. And that's due to clinician inexperience, but also time constraints in clinics, and previously lack of clear agreed upon glycemic targets. This led to the publication of in just this fall, in September of 2019, in Diabetes Care, of a consensus of what the international groups feel should be the goals for CGM therapy. A group called the Advanced Technologies and Treatments for Diabetes Congress convened, and they authored this consensus with providing recommendations for CGM data utilization and reporting. Prior to that, the reports that you would get from these various sensors were not very standardized. And they also worked to simplify the data. I think it's important to point out that this Congress that wrote these guidelines was comprised not only of diabetes providers and researchers, but also diabetes or individuals living with diabetes themselves that had a lot of experience with CGM. And in this publication, they listed the standard CGM metrics that all devices should include on their reports. And then they also published what those targets should be. And they based targets, or they included targets for type 1 and type 2 diabetics, older high-risk type 1 and type 2 diabetics, patients, type 1 diabetics who are pregnant, and type 2 or gestational diabetics who are pregnant. We'll focus on our more common patient population, the type 1 and type 2 diabetics. And they recommended that a goal for patients when you're seeing them in clinic is to try to achieve a time in range of greater than 70%. Time below range should be less than 5%, with less than 1% being less than 54 or severe hypoglycemia. And the time above range should be less than 30%. For older diabetics or patients with high risk or high risk comorbidities like cardiovascular disease, osteoporosis, cognitive issues, patients whom you really want to avoid hypoglycemia, your target range goal should be 50%, and your hypoglycemic or less than 70 goal should be less than 1%, because the priority for these patients is to limit hypoglycemia. These targets come from data that is demonstrated. There's two different studies that were published in 2019, actually, that time and range of 50% correlates with an A1C of about 8%. And so that's where these are coming from, these guidelines. And a time in range of 70% correlates with an A1C of around 7%. But not only does time in range correlate with A1C, it also correlates with complication rates. Another study published by Beck last year validated time and range outcome measures for patients in the diabetes control and complication trial. This was a large study, kind of a landmark study, famous for endocrinologists, that first published in the 1980s, and there's been multiple studies looking at how more intensive control is associated with improved outcomes. And patients in that study were required to check their blood sugars 7 times a day. And so back then they didn't have CGM, but they used the 7-point blood glucose data to calculate time and range. And what they saw was the more time, for each 10% decrease time and range, the frequency of retinopathy was decreased. And the same was true for each 10% decrease in time and range, the development of microalbuminuria decreased. And these were in type 1 diabetics. Liu et al. Published a similar type of study looking at type 2 diabetics, over 3,000, and they showed that a lower advanced diabetic retinopathy was associated with a lower time and range, and the severity of diabetic retinopathy was inversely correlated with time and range. And I think this just speaks to the fact that as more patients are using CGM, we'll be able to move beyond A1C as a marker of glycemic control. A1C is really a population-based method, or measure of population health, and it's a surrogate for long-term risk of diabetic complications, but it doesn't really, it has a lot of limitations. Number one, it doesn't tell you anything about the acute fluctuations that happen in a given day that a diabetic might have, and it can be affected by many other things that patients may be experiencing, like anemia, hemoglobinopathy, iron deficiency, hereditary differences in glycation. And it's really difficult to use this single value representing an average of 2 to 3 months to individualize management. And I think that's where the role of CGM plays, is that it really allows for direct observation of glucose excursions, and which the patient can use to immediately inform their therapy decisions or lifestyle modifications. And with the studies I've presented, small incremental changes in time and range of only 5% can really have clinically significant outcomes. So I'll finish up the talk today showing you what a standardized CGM report looks like. This is what the recommendations were as a result of that Congress that convened last year. And this single-page summary is recommended to have 3 different components: a component of CGM metrics, the ambulatory glucose profile, and daily glucose profiles. So let's look at each part separately. So in terms of CGM metrics, one key component of that is how often the CGM is active. You can see here on this report that in the last 13 days it's been used 99% of the time. And really, you want to see this number, percent active, greater than 70% to be confident that the information that you're getting from it is useful. This lists what the targets are for each of the time ranges. Here listed is the average glucose, which we're familiar with, but it also includes something called the Glucose Management Indicator, or GMI. On previous old versions of these reports, it was called called the estimated A1C, which provided a lot of confusion because oftentimes this GMI doesn't correlate with the patient's A1C. This value is being calculated from the sensor data and taking into account the time spent above range, below range, and so this may not be the same as a patient's A1C, particularly if they have a lot of glucose variability. And one of the other metrics included in these reports is a comment on the glucose variability using the coefficient variant, and the target is to achieve a CV of less than 36%. So above that, you really want to assess what might be contributing to why the patient's blood glucoses are so variable. And then, of course, the metrics will include the time and ranges, and the targets are listed next to it so that you can to serve as a reference. The second part of the summary report is the ambulatory glucose profile, and this provides an average of what the patient's blood sugars are doing from midnight to midnight over the past 14 or 30 days, whatever the data set for. And this provides really a wealth of information for helping the patient to understand what they can do and how you can help them improve their glycemic control. This solid line is the 50 percentile line, and then the dark blue is the 25th to 75th percentile, and light blue is 10 to 95th percentile. So my approach to looking at this and having it printed out with the patient is to mark directly on the profile when the patient is waking, when they're having breakfast, when they're having lunch, when they're having supper, when they're going to bed, and marking right on this profile when they're taking insulin and how much. And also ask them about consistent times of exercise or consistent snacking, and then show this data to the patient and include them in the process of interpreting the information. And you can really find a lot of insight by going through this data with the patient. You may find that when they look at this, they're like, well, a lot of times I am missing my meal bolus with breakfast. That might be what's going on there. Or, oh, I tend to eat on the run and I wait to take my insulin until I get to work because I'm afraid of going low on the car ride to work. And so it provides a tool for you to have a conversation with the patient about how they're managing their diabetes and what changes can be made. And a lot of times it's not that they need a change in their dose, but they need a change in the behavior. I think the daily glucose profiles are helpful to see if there are days of the week or certain patterns to both highs and lows. And when I'm looking at this data, I think it's important to first address the hypoglycemia. That's what's going to be most acutely dangerous to the patient. And you can see when someone is having frequent hypoglycemia, or if they've had hypoglycemia, what follows the hypoglycemia is hyperglycemia in response to treating the low. And so by focusing on the hypoglycemia first, you can also correct some of the hyperglycemia. If a patient doesn't have much hypoglycemia, then of course you would move on to the hyperglycemia. But I think the daily profiles can provide some insight. For instance, the patient might say, well, every Tuesday and Friday I go play soccer at the local soccer club, and that might be why they're having their lows overnight because of that activity. Another advantage is that hopefully these reports are being downloaded into the patient electronic health record, and you can bring up these reports and compare your current report to their prior to report to assess for improvement, gains in control, or perhaps some changes that are not so good, and can kind of talk about what has changed in terms of their work schedule, their stress levels, their other health conditions. And I think it's important when we get all of this information, it's really tempting to make all sorts of changes as a result. But I really try, after reviewing this data, to focus on 1 or 2 recommendations that the patient has agreed upon that will be most beneficial. If you make so many changes all at once, it's hard to know which benefited or not. If you have further questions about devices beyond sensors, including insulin pumps and what have you, I would refer you to the diabeteswise.org website. This is right on their homepage, helping you find the right diabetes for your life. There's lots of online resources, online quizzes that you could work through with your patient. A last note on insurance coverage. It's a big topic that comes to our clinic, and I will inform you of what Medicare and Quartz covers, which is pretty similar actually. For Medicare patients, they require that a patient be checking 4 times daily for the past 30 or 60 days, and there needs to be a documented printout. The patient must be using 3 or more insulin injections a day or an insulin pump. And you have to document in your note, in addition to that, that they're making frequent adjustments in their insulin regimen in order to qualify for Medicare coverage of CGM. Quartz, they recommend or require, that patients are testing 3 times daily for the past 90 days. And again, patients must be using 3 or more insulin injections daily or an insulin pump for at least 6 months before they will approve it. And we are happy to see patients in clinic to talk about sensors. But one key point I want to make is that being seen in the diabetes clinic doesn't expedite the ability to get a sensor. All of these insurance companies require that this criteria be met before coverage. And so if a patient isn't able to meet these requirements, they're not going to be able to get coverage for the device. So some take-home points for you today. What we're trying to achieve, what the primary goal is with sensors, is to have effective and safe glucose control by increasing the time that a patient is in range and reducing the time that a patient is below range. And I hope I've demonstrated that there have been multiple randomized controlled trials showing that with consistent CGM use, this primary goal can be achieved. I hope I've also demonstrated that CGM data can be used as a shared decision-making tool with patients. And the data collected by these devices allows for greater personalization of their therapy than the A1C measurement alone. And as with any sort of treatment, patient selection and initial as well as ongoing education are really key for CGM success. That's all. Thank you.
Thank you very much. Questions?
Yes.
So I guess I'm understanding, since you can only wear these things for at most, say, 2 weeks at a time, that the time they will be used is either somebody who's been followed for a while and they just don't seem to be getting it together, or because you can't, if you describe the device that you put on your arm, can you use that again once you take it off?
That's a great question. So the professional...
So repeat the question.
Oh, thank you. Can you use the devices for longer than the 14 days, the amount of time that I listed? And I should have been more clear. So that when you are using a CGM as a personal device, you are prescribed multiple sensors. And so you replace that sensor every 14 or 17 days so that you can be using it on a regular basis.
But you don't, do you intend to have these people on these devices continuously, or only at the times that you feel that something is not working right, or maybe the first time you see them and they're
Yeah, that's a great question. So do you intend for patients to use them continuously or only when you are anticipating they are having problems? And I would answer that by saying it's dependent on the patient. If a patient wants, I would say majority of my patients are using them continuously because they value the data that it's giving them on a regular basis. But then I have some patients who will use it for the week prior to their appointment with me so that we have more data to review at that appointment. And so it's really patient dependent.
Dr. Parsi.
Thank you. Great information, and I think it certainly provided me some new insights. What I'm wondering, a lot of these kinds of feedback mechanisms are there to influence patient behavior and ultimately then medical outcomes. So I'm wondering, to what extent have these kinds of devices integrated with activity monitors such as accelerometers and actigraphs? Because as people start to create rhythms in their life, they can get feedback about what rhythms are positive and what rhythms are negative. And so, do any of these devices have either accelerometers, or do they integrate data with activity monitors?
It's a great question, and the question is, do these CGM devices integrate with activity monitors? Are there any studies that show correlation that these devices increase activity? And in actually one of the studies that I didn't focus on in the beginning here, the short answer is that I'm not aware of any current devices that are integrated with an accelerator, but I'm sure that may change in the future. And I do have patients who notice that when they're walking, their blood sugars come down, and so they'll actually increase their activity to regulate their blood sugars. So they're not necessarily looking at the step data, they're looking at their sensor data and seeing that when I'm walking, my blood sugars are coming down. And so they're, in effect, sort of using it that way. It's not measuring the amount of steps or how much energy is being burned, but I do have a lot of patients that use that sensor data, like after dinner, if their blood sugars are running higher than they expected, they go on the exercise bike and help and work to bring their blood sugars down as a result. And I'm sorry, I can't find the exact study, but one of the randomized controlled trials showed that the patients using these sensors had significant changes in lifestyle factors, weight loss, increased reported activity. I mean, again, these are small studies and these are select patients, but I've seen it in practice as well.
Thank you very much. Any other questions?